Our next topic is neonatal jaundice. Remember that infants are prone to get jaundice as they have high RBC count and immature liver to process bilirubin. So that's why they are at a risk of getting jaundice. Now there are two types of jaundice. One is physiological jaundice and one is pathological jaundice. What is physiological jaundice? Physiological jaundice is usually harmless. It's a normal physiological process. It usually presents after 24 hours to 2 weeks. 24 hours to 2 weeks after birth. It is usually harmless and does not need any treatment but it needs to be continuously observed. While pathological jaundice is if jaundice persists after 2 weeks after birth, then this is known as prolonged jaundice or pathological jaundice. Usually the bilirubin level is very high, the baby is irritable and is not feeding well. So pathological jaundice basically present within the first 24 hours and it persists after 2 weeks after birth. And physiological jaundice present after 24 hours and persist for 2 weeks. So jaundice on the first day of life is always pathological. Jaundice after 2 weeks of life is always pathological. And jaundice in the period between after 24 hours to 2 weeks is physiological. Now let's discuss some causes of pathological jaundice.
Can you say
Remember
that again,
this?
please?
Yes.
The first day, if there is jaundice on the first day, will it be pathological or will it be physiological?
Jaundice on the first day of life is always pathological. In the first 24 hour, jaundice in the first 24 hour is always pathological because physiological jaundice start at the second day of life.
So from 24 hours onward to 2 weeks, then it is physiological.
Yes.
Right. It's a bit confusing.
Because when the baby is born, and if he's born with the jaundice, then it is pathological because there are conditions such as hemolytic disease of the newborn or hereditary spherocytosis. They usually manifest in the first 24 hours, while on the other hand, physiological jaundice appear after 24 hours. Because in the first 24 hours, usually there is breakdown of the RBCs or the old RBCs are broken down. And then when they are transported to the liver of the infants is immature. So that's why physiological jaundice, it appears after 24 hours.
Right.
So the duration for physiological jaundice is 2 days to 15 days or 2 days to 2 weeks.
Right.
Start on the second day and ends on the 15th day or ends in 2 weeks.
Right. And also after 2 weeks, if it is continued, then even then it is pathological.
Yes. A jaundice that is present on the first day or that is persisted after 2 weeks is pathological jaundice. And then we need to investigate the cause if that's the case.
Right.
So causes of jaundice in the first 24 hours. In the first 24 hours, the causes of jaundice is hemolytic disease because of RH incompatibility or because of ABO incompatibility. The baby will develop jaundice within the womb of the mother. And when he is born, he will be born with jaundice. Similarly, other genetic conditions such as hereditary spherocytosis or glucose 6-phosphate dehydrogenase deficiency, they can also present with jaundice in the first 24 hours. So remember that these four causes, they can cause jaundice within the first 24 hours. Include one other cause of jaundice in the first 24 hours, that is congenital hypothyroidism. So these are the causes of jaundice in the first 24 hours. Disease hemolytic disease, aviohemolytic disease, hereditary spherocytosis, glucose 6-phosphate dehydrogenase deficiency. Now, jaundice in the neonates from 2 to 14 days is common in up to 40% and usually is physiological. So if there are still signs of jaundice after 14 days of delivery, a prolonged jaundice screen is performed. So a prolonged jaundice screen is performed, including conjugated and unconjugated bilirubins. So the investigation that need to be done if jaundice persists beyond 14 days after delivery. The first of them is conjugated and unconjugated bilirubin levels, because this investigation will help us in differentiating between conjugated hyperbilirubinemia and unconjugated hyperbilirubinemia, because the causes of conjugated hyperbilirubinemia is different and unconjugated hyperbilirubinemia is different. Hereditary spherocytosis, for that we need to do a Coombs test, thyroid function test to rule out congenital hypothyroidism, full blood count, peripheral blood film, urine for microscopic culture and sensitivity, LFTs, etc. All these investigations need to be done to see what is causing this prolonged jaundice. Now, we'll discuss one by one the causes of prolonged jaundice. Now, biliary atresia. Biliary atresia is a condition in which you can say there is no common bile duct. There is no problem with the liver, but problem is with the transport of the bilirubin. So in biliary atresia, what will happen? Signs of obstructive jaundice will be present. There is obstruction to the flow of the bile. Liver is conjugating the bilirubin normally, but there is obstruction to the flow of the bile. So conjugated or direct bilirubin will be raised. Normally, the bile is transported through common bile duct into the second part of the duodenum, and then it is excreted in the feces. So the normal color of the feces is due to presence of the bile or bilirubin. So what will happen if there is no bile is not transported to the GIT tract? The color of the stool will become pale. So the features of obstructive jaundice, the features of obstructive jaundice include pale stool, dark urine, and hepatomegaly. Pale stool because jaundice is obstructed, transport of bilirubin is obstructed, which lead to pale stool or clay color stool. The urine is dark because conjugated bilirubin is water soluble. It is absorbed in the circulation and is excreted in the kidneys. So decreased excretion through GIT tract lead to pale stool, and increased excretion through kidney lead to dark urine. And because there is a stasis or obstruction to the bile, so hepatomegaly will also occur. And failure to thrive is also a feature of obstructive jaundice due to biliary atresia. So if a child presents to you just beyond 14 days of life and he's complaining of pale stool, dark urine, and hepatomegaly, then your diagnosis will be biliary atresia. So I hope the features of obstructive jaundice is clear to everyone. Now, the second cause of prolonged jaundice is congenital hypothyroidism. Along with jaundice, other features of hypothyroidism will also be present, such as constipation, cold, mottled, dry skin, hypoactive baby, failure to thrive, protruded tongue, flat nose, widely set eyes. Protruded tongue, flat nose, and widely set eyes. So remember that these features can also be present in Down syndrome as well. But in Down syndrome, there's no jaundice, or there's no constipation, or there's no cold, mottled, dry skin. So a jaundice with features of hypothyroidism, your diagnosis will be congenital hypothyroidism. Jaundice with features of obstructive jaundice, such as pale stool, dark urine, hepatomegaly, your diagnosis will be biliary atresia. Then there is breast milk jaundice, then there is galactosemia. Breast milk jaundice and galactosemia, they both causes unconjugated hyperbilirubinemia. How we can differentiate between breast milk jaundice and galactosemia. A child who present to you with unconjugated hyperbilirubinemia, and there he complains of vomiting, difficulty feeding, diarrhea, jaundice, failure to thrive, then your diagnosis will be galactosemia. And if the person present to you with, or the baby present to you with jaundice without these features, there is only jaundice, but the baby is feeding well, and there is no vomiting or diarrhea or failure to thrive, then the diagnosis will be breast milk jaundice. So in breast milk jaundice, you can say that the only feature is jaundice. There will be no other symptoms such as vomiting, difficulty feeding, diarrhea, jaundice. So along with unconjugated hyperbilirubinemia, if vomiting, feeding difficulty, and diarrhea they are present, then your diagnosis will be galactosemia. Urinary tract infection and congenital infections such as CMV and toxoplasmosis, they can also lead to jaundice. Again, jaundice that is present at birth or within 24 hours is pathological, and it needs to be further investigated for hemolysis due to races or ABO incompatibility, or hemolysis due to G6PD deficiency or hereditary spherocytosis. Jaundice that is present beyond 2 weeks needs urgent pediatric assessment. First of all, we need to check split bilirubin levels to see if unconjugated bilirubin is raised or conjugated bilirubin is raised. If conjugated bilirubin is raised, you will think of biliary atresia. If unconjugated bilirubin is raised, you will think of breast milk jaundice or galactosemia. Breast milk jaundice is more common than galactosemia. Now we'll discuss one by one the causes of neonatal jaundice in detail. So the first of them is biliary atresia. Biliary atresia leads to obstructive jaundice, which will present to us with pale stools and dark urine, and hepatomegaly. Splenomegaly can also be a feature, but it is present when the patient present to the clinic or to the hospital very late. The diagnosis of biliary atresia is confirmed by conjugated hyperbilirubinemia, raised GGT, abdominal ultrasound, cholangiogram, and percutaneous biopsy is the most definitive test to make a diagnosis of biliary atresia. The treatment is usually surgery, and the name of the procedure is Kasai procedure, in which Kasai procedure in which there is hepatoperitoneostomy and trostomy is done. Now, a condition that you need to differentiate from biliary atresia is galactosemia. Biliary atresia cause conjugated hyperbilirubinemia and galactosemia cause unconjugated hyperbilirubinemia. So both of them will cause prolonged jaundice. The first difference is that one causes conjugated and other causes unconjugated hyperbilirubinemia. There will be pale stools and dark urine in biliary atresia, and there will be yellow stools and pale urine. Remember that unconjugated bilirubin is water insoluble. So because there is increased unconjugated bilirubin, so the urine will be pale. In obstructive jaundice or conjugated hyperbilirubinemia, stool are pale but urine is dark, while in case of uh, unconjugated hyperbilirubinemia, pale urine and yellow stools. So remember these clinical features which will help you in differentiating between conjugated and unconjugated hyperbilirubinemia. The common features of both of them is prolonged jaundice, liver enlargement, lethargy, feeding difficulties, low for weight for age. Biliary atresia present with features of obstructive jaundice, while galactosemia does not present with features of obstructive jaundice. For example, an 8-week-old baby presents jaundice. So baby is 8 weeks old and he is having jaundice, so it's prolonged jaundice. Yellow stool and pale urine. So yellow stool and pale urine is a sign of unconjugated hyperbilirubinemia, liver enlargement, low weight, difficult feeding, and vomiting. So galactosemia is the diagnosis. So why not breast milk jaundice? Because breast milk jaundice can also cause unconjugated hyperbilirubinemia. So why we have selected galactosemia as our answer? Can somebody of you tell me why galactosemia is the answer of this scenario? Why not breast milk jaundice?
There's no feeding problem in breast milk jaundice.
Yes, there is no feeding problem. There is no vomiting. The weight of the baby will be normal. In breast milk jaundice, there will be no liver enlargement as well. So yes, these are the features which will help you in differentiating between breast milk jaundice and galactosemia. Galactosemia is an autosomal recessive disease in which there is a deficiency of this enzyme that is known as GALT, G-A-L-T. This enzyme converts galactose 1-phosphate to UDP glucose and then UDP galactose and glucose 1-phosphate. So basically you can say that GALT convert galactose into glucose. So when there is deficiency of this enzyme, galactose is not converted to glucose, which leads to buildup of galactose in the liver and result in the jaundice. So the treatment for galactosemia is a low galactose diet. So we'll avoid milk and other foods that contain lactose or galactose, because lactose also contain galactose. So milk or foods that contain galactose and lactose, they should be avoided, because this is the only treatment option that we have for galactosemia. Now, the second cause of unconjugated hyperbilirubinemia is breast milk jaundice. It is the most common cause of prolonged unconjugated hyperbilirubinemia. The infants become jaundice in second week of life. They are usually well. and jaundice resolves within 6 weeks, but it may continue up to 4 months. Again, the diagnosis, the investigation that we need to do is to do split bilirubin tests to see conjugated and unconjugated bilirubin levels. The management is that in majority of the infants, interrupting breastfeeding is not necessary or advisable because it is a self-limiting condition and it resolves after 6 weeks or after 2 to 3 months. So mothers are usually advised to continue breastfeeding because with breastfeed they are not getting any problem. They are usually well vomiting, so there is no need to discontinue the breastfeed. Occasionally, breastfeeding may be stopped for 24 hours and formula is given till the diagnosis is established. What is the cause of breast milk jaundice? Remember that breast milk contain a chemical pregnane 3A 2O beta diol and beta glucuronidase. So this pregnane and beta glucuronidase they lead to an increase in the unconjugated bilirubin levels. That's why breast milk can cause unconjugated hyperbilirubinemia because of increased activity of these chemicals such as pregnane and beta glucuronidase. Breast milk can also lead to jaundice, that is known as breast milk jaundice. Treatment is not necessary for breast milk jaundice unless the infant's total serum bilirubin is greater than the phototherapy guidelines. So remember that what are the phototherapy guidelines? In all cases of jaundice, when you will go for phototherapy. A commonly rule of thumb is to start for phototherapy when the total serum bilirubin level is greater than 5 times of the birth weight. For example, if the baby weight is 1 kg and his bilirubin is 5 milligram per deciliter. So the indication for phototherapy is that total serum bilirubin level should be greater than 5 times of the birth weight. So if a 1 kg infant, then the indication for phototherapy will be a bilirubin level of 5 milligram per deciliter. While in a 2 kg infant, phototherapy will be started if bilirubin levels are 10 milligram per deciliter. Similarly, for a 3 kg individual, 5 times is 15 milligram per deciliter. So this is according to NICE, this should be used a criteria for phototherapy. Now, the other scenarios, if the total serum bilirubin level remains below 12 milligram per deciliter, the recommendation is to continue breastfeeding. If total serum bilirubin level is higher than 12 milligram per deciliter, but below the phototherapy level, and further investigation shows no hemolysis evidence, again, we will continue breastfeeding. When the bilirubin level is greater than 20, then a brief 24-hour cessation of breastfeeding may be beneficial. So in short, if bilirubin level are below 12 milligram per deciliter or above 12 milligram per deciliter and below the phototherapy level, then we'll continue the breastfeeding. And if bilirubin level are 20, then breastfeeding can be discontinued for a period of 24 hours. So in short, no treatment for breast milk jaundice is required. Phototherapy can be done if bilirubin level is greater than 5 times of the birth weight. So
Can
this
you
was all
explain
about
again about the phototherapy, when to start? Greater than 5 times of the birth weight. Can you please explain that
yes,
again?
greater than 5 times means if birth weight is 1 kg, then greater than 5 times means for a 1 kg infant, the bilirubin level of 5 milligram per deciliter is greater than 5 times the birth weight. Similarly, for a 2 kg infant, a 10 milligram per deciliter of bilirubin will be 5 times the birth weight. Similarly, for a 3 kg baby, 15 milligram per deciliter will be the indication for phototherapy, and so on.
Right.
While about continuation or discontinuation of the breastfeeding is that we will continue the breastfeed if the bilirubin level is less than 20 milligram per deciliter without any signs of hemolysis or without any evidence of hemolysis. But if the bilirubin level is greater than 20, then we can stop the breastfeeding for 24-hour period, and then it can be resumed again after 24 hours are passed. So this was breast milk jaundice. Now there is another category of jaundice that is breastfeeding jaundice. So there is a difference between breast milk jaundice and breastfeeding jaundice. Breast milk jaundice is due to presence of chemicals such as pregnane in human breast milk that can lead to jaundice, while breastfeeding jaundice is exaggerated physiological jaundice associated with inadequate milk intake. Normally, as we know that bilirubin is excreted or biles are excreted in the feces. So if baby is inadequately breastfeed, it means newborn who nurse every hour or two have frequent stools, and this eliminate bilirubin from the intestine more efficiently. So babies whose intake is suboptimal because of suboptimal intake of milk, what will happen? They will get less frequent stools. And as bile is or bilirubin is excreted in the stools, so because of less frequent stools, what will happen? Accumulation of bilirubin will occur due to reduced number of stools, and thus the resulting jaundice will be known as breastfeeding jaundice. So the only difference between breast milk jaundice and breastfeeding jaundice is that breastfeeding jaundice is due to inadequate breastfeeding and buildup of bilirubin due to decreased number of stools. So in the history, it will be mentioned that baby is inadequately breastfed and he has developed jaundice. So is it clear the difference between breast milk jaundice and breastfeeding jaundice? Is there any confusion?
No, it's fine.